Hello, everyone. Welcome to Spine Time. My name is Joshua Weaver. I'm a neurologist and one of the co-directors of the Spine Center at Weill Cornell. Today, I am your host and moderator for our Spine Time webinar. It's my great pleasure, together with my co-directors and the staff here at the Spine Center, to welcome you to our latest installment of our Spine Time webinar. Today, we're covering a really important topic. Why is back pain so complicated? The importance of having a multidisciplinary care team. Next slide. I want to thank the speakers today and our co-directors and the staff. I also want to thank Roseanne, Tatiana, Paul, Sue, Madeline, and the team at the neurosurgery group at Cornell for putting these webinars together. As you may know, we work at 59th Street and 2nd Avenue at the Weill Cornell Medicine Center for Comprehensive Spine Care. We have over 20 physicians on staff. We have physiatry and sports medicine. We also have pain management, neurology, and neurosurgery faculty as well. We also work really closely, as you can see on the slide here, with our integrative medicine doctors and complementary medicine practitioners, as well as psychologists at Weill Cornell, to really take a comprehensive care of our patients and a holistic management plan for them. Before we start with our speakers, I just want to say a few words about our webinar. Many of you have submitted some really great questions, and unfortunately we can't always get to all the questions that may come up. There is a website, spinewebinar.org, where you can submit questions, and we'll try to get to those. I think there's also an email blast that's sent out via that website if you sign up, and you're able to email questions through that as well. And we do try to get to those. Since these webinars are being recorded, we wanted to remind you to turn off your videos, as there will be, this will be available for viewing online on YouTube. During the course of the webinar, there is a chat function on Zoom, and we highly encourage that you ask questions. We will try to get to most of those during the 45 minutes that we have allotted. So I am proud to introduce our speakers. We have two esteemed speakers today who I know very well. On the left, we have Dr. Vincent Miccio, who is board certified in physical medicine and rehabilitation and in interventional pain medicine. On the right, we have Dr. Eric Ellowitz, who is an experienced neurosurgeon at Weill Cornell, who specializes in minimally invasive spinal surgeries. So without further ado, let's go ahead and start. We're going to actually start with you, Dr. Miccio. Why don't you tell us a little bit about yourself and your experience with the multidisciplinary care that we provide at the Spine Center? You're still muted, Dr. Miccio.
Thank you. Thank you very much. Thanks for that kind introduction. As Dr. Weaver has mentioned, my name is Vince Miccio. I am a rehabilitation and interventional pain physician working at the Spine Center on 59th Street. I have been with the practice since 2017, and I see a variety of conditions, including back pain, neck pain, and joint pain. I'm excited to talk to you about this subject today because back pain really comprises a large part of my practice. And I really have to counsel my patients through their symptoms, really counsel them about appropriate diagnosis and treatment, and kind of see them through the whole spectrum of care. And it is very, very complicated. And it's very interesting because, back pain, it's not something foreign to people. This is something that most people have at some point in their life. And according to the WHO, up to 60, 70, even 80% of people will have back pain at some point in their life. This is not a topic that is foreign to most of us. Most of us have had back pain at some point. This has been around for centuries. Ever since we started walking on 2 feet, people have had back pain. Just as an interesting side note, there are actually recorded cases of back pain in some of the most early medical texts that we have, as far back as 1500 BC. And despite the fact that this has been around for centuries, we really have not gotten down to explaining exactly what causes back pain until most, very recent times. So, the exact causes of back pain have been somewhat elusive. In the 500s and around the time, even later in the Renaissance, people would say that this is actually an example of the Elf's arrow, which is Hexenschluss, apparently, which is they thought that back pain came from being shot with an elf's arrow, and being shot with the elf's arrow would cause pain in the back that shot down your leg. Believe it or not, we've really struggled to explain exactly what causes some of the myriad symptoms of back pain, and it wasn't until 1924 that Mixter and Barr, this is a team at Mass General Hospital, a neurosurgeon and an orthopedic surgeon, teamed up to publish a paper that hypothesized that a ruptured disc in the lower lumbar spine could cause nerve compression and could cause this phenomena of sciatica that we all know so well. So this is very, very recent in the course of human history, and yet back pain has been with us for a very, very long time. One of the things that makes back pain so incredibly complicated is that pain in the areas that you see in front of you here can be explained by this. The list is extraordinarily long, and this is what makes this a bit of an art. And this is what makes a multidisciplinary team so vital to the treatment, to the diagnosis, and to the treatment of back pain. We are a team at the Center for Comprehensive Spine Care. As Dr. Weaver mentioned, this team is comprised of several team members. Today, we have Dr. Ellowitz from neurosurgery, we have Dr. Weaver from neurology, and myself from rehabilitation and pain medicine. We also have colleagues from radiology that help us obtain a definitive and appropriate diagnosis for our patients. And we all weigh in on this because there are different perspectives and there are different kind of perspectives to really obtaining an accurate diagnosis. From my standpoint, the question is usually, is the pain coming from a musculoskeletal origin, or a neurologic origin? And so a good example of that is the pain coming from the back, or is it coming from the hip? It is often not very clear. And in that instance, really laying your hands on the patient and actually getting a thorough physical examination can really help point us in a direction towards an appropriate diagnosis. But very often that diagnosis or that the physical examination points us in multiple directions. So sometimes what we have to do is we have to, and many people in the audience today will probably hear this, or this will sound familiar because I say this to my patients all the time. I say, it's my job to come up with a differential diagnosis. There's a list of potential things that this could be, and we start crossing those things off. Sometimes it requires some targeted injections to joints or around nerves to see if those injections relieve pain. That can really help us narrow down the diagnosis. On the neurology front, neurology can assist with performing nerve testing, which allows us to diagnose various neurologic issues, and it gives us a sense about where the nerve compression is happening, and also a little bit about the chronology of it and the severity of it. So when, especially if there's a neurologic diagnosis in question, the EMG can really help us narrow it down to a specific location. Neurology can also assist us with investigating if there are other more systemic neurologic issues at play, for instance, multiple sclerosis and such, that could present as some weakness and some discomfort, that may require additional testing in the form of lumbar puncture testing or blood work and laboratory testing. Radiology, of course, assists us with imaging in the form of X-rays, MRIs, CT scans, and sometimes a myelogram as well. The diagnosis is the first step. We really have to figure out where the pain generator is and where the pain is coming from. Back pain is a symptom, and that is not good enough. What we seek to do is really narrow it down to a specific pain generator. Next is finding an appropriate treatment. I say this to my patients all the time. I say it's my job not to undertreat you, and it's also not my job to overtreat you. So we have to find the right treatment for the stage of pathology that you're in. Some elements of this include the timing. Is this an acute injury that flared up a week ago, or is this back pain that's been lingering for 20 years? The treatment for those two things is extraordinarily different. The pain as well. Is this pain a low-lying, lingering pain, or is this a sudden flare-up of severe pain? Again, those are treated in very different ways. The functional element cannot be ignored. Does the patient have relatively full function? Can they go about their activities of daily living uninterrupted? Or do they have severe numbness and weakness that is making everyday activities quite difficult? And sometimes we can find that patients have this and they don't have much pain, or they have significant pain, but they're relatively functional. These are all different dimensions. One dimension that I like to say is the suffering dimension. So there's the structural element to this, what the back looks like and the injuries that are present, but there's also our perception of it and our life experience of it. That can range from patients who have severe pain, but they say, I'm not bothered by it too much. It doesn't really affect me. I grit my teeth and I work through it. But however, you could have somebody who loves running. They absolutely love to run, but their back hurts when they run and they're absolutely crushed because they cannot run because of their back pain. Those patients are treated quite differently. When it comes down to it, we offer a variety of treatment to our patients. Often they come in the form of exercise, medications, injections, and at times surgery. I will put in an asterisk here that there are others. There are other treatments that we offer, acupuncture, manual therapy, shockwave therapy, green laser therapy, ultrasound, electrical stimulation. All of these therapies are appropriate in the right patient at the right time for the right type of pain. And that's where the art of this comes in, and that's what makes it so complicated. So that's a brief introduction to kind of how we operate a bit as a team. This is the tip of the iceberg. And I'm going to go ahead and turn it over to Dr. Ellowitz, who's going to walk us through pathology as well as a case.
Yeah, thank you, Dr. Miccio. One of the most common entities that we see in our patients is something called lumbar stenosis, which is a narrowing of the spinal canal. And it's really pretty typical that the spinal canal will narrow over time, combination of arthritic conditions, bone spurring, increase in ligament. But in many patients, that can start to cause symptoms. That can cause leg pain, problems with walking. Many patients tell me that they walk a certain distance and then have to stop, sit, and then continue on because they just can't, they have too much pain. They'll say their legs either pain, sometimes described as heaviness. A lot of treatment options for this. And I think that's really one of the major advantages of having a comprehensive spine center, such as we have at Cornell. Because in essence, it's really one-stop shopping. They may come in to see me as a surgeon, and I may say, let's try a couple other things before thinking about surgery. Even though I'm a surgeon, I'm also very conservative about recommending surgery. And in the vast majority of cases, we will want to try some non-surgical treatments first. We have a whole range of those, everything from physical therapy, steroid injections, medial branch blocks. There's a whole lot of options. So in many ways, what we have at the Spine Center is really one-stop shopping, where instead of having an appointment to come in to see one doctor, let's say they see me and I say, you know what, maybe we'll have you see a neurologist, and I have to make another appointment, come back a different day. Really adds to efficiency. It adds to the treatment, and really the goal is to get people back active and functioning and comfortable, no matter however way we do it. So I just really want to say that it's really this comprehensive nature, this one-stop shopping, where someone may come in to see one of us and then wind up on the fly seeing someone else, or making a joint appointment. We will be more than happy to do that, kind of like a comprehensive evaluation with more than one specialist.
If I may, it's actually not uncommon for Eric to come and track me down and say, hey, I have this guy, I don't think he quite needs surgery, but maybe you could evaluate him. And very often that same patient that he has seen for a neurosurgical evaluation is then evaluated by me, and quite often I am able to do a same-day injection for that patient. So just as Dr. Ellowitz was saying here, this is an efficient system. I think it's kind of easy for us to get down about our current medical system, but this is actually an aspect of our medical system that's working quite well, because we're all under one roof, and it leads to a lot of continuity of care. And to be honest, if I was a patient, this is what I would want. I would want to be able to come in and to be able to see several specialists in the same location, and in the best case scenario at almost the same time. So it works quite well.
Yeah, thank you guys for that overview. That was really wonderful. Hopefully we've come a long way since in the last 1,500 years trying to figure out what causes back pain. And definitely a lot of different ways to evaluate patients and a lot of treatment options. I know there are a couple of cases that you guys wanted to present, but we are getting a lot of questions coming in. I thought I would throw a couple of those out at this point just to see what you guys thought. There's sort of a general theme here about a lot of people who've had, pretty bad back pain, and they've tried various treatments, medications, acupuncture, physical therapy, and sometimes it's just not getting better. I think I think it was Linda might have asked, when do I know when surgery is the answer? When do I go for surgery? And another sort of related question was, do pain meds get addictive, and do I need to be worried about being on pain meds for too long? Should we jump to do surgery sooner, for that reason? Maybe Eric, you can start.
There are a lot of potential reasons when to consider surgery. One of the questions that I ask patients pretty routinely is how is the pain affecting their activities and their function? It really comes down to quality of life. Someone could have pain, but then say, well, it really doesn't affect me. Then I'd say maybe it's not time to think about surgery. If someone could do really everything that they need to do or want to do, but on the other hand, if pain is really limiting their function and activities, then surgery may be a consideration. But as I mentioned, but certainly in the vast majority of cases, would want to try some non-surgical treatments first. Plus, we haven't spent a lot of time talking about the actual imaging, MRI scans, but when we consider surgery, we need to see something on an MRI or CAT scan where we know that we could fix. And it's not just a matter that someone has pain and we do an operation. Really, the procedure, the surgery, or even if it's non-surgery, needs to be customized to the individual and what their actual problem is. And there are many cases, unfortunately, where I may tell people that surgery does not have a high likelihood of helping their symptoms, and then we may have to come up with other alternative treatment strategies.
And Vince, maybe you can jump in on that too. I really like the idea of the functionality, talking about that as a big sort of symptom of what people are going through, right? How much do their symptoms actually get in the way of their functioning, and also their quality of life, I think, can be really important. You, Dr. Miccio, you had brought up, also looking at people's suffering and different kinds of suffering, and how we want to approach that, because sometimes that can relate to pain, very well. Maybe if you want to just bring up a little bit about what you do for that, because sometimes when surgery is not an answer, there's a lot of different therapies that we might be able to do.
Absolutely. I would start off the answer to that question by saying, in front of us here, we have an MRI that very clearly shows lumbar stenosis, but that's just a picture. So we don't treat pictures, we treat patients. And I have patients all the time that come to me and say, I have 3 herniated discs. And what's really key is, I say to them, that's fine, that's okay, we'll go over that. But first, tell me what you're feeling. Tell me what you're experiencing. Tell me how it affects your life. Tell me what you do for a job, and how that affects things. And then we go to the MRI after doing a thorough history and a thorough physical, and we correlate what they're experiencing with the imaging. It's not the other way around in the vast majority of cases. It's really what the patient's experiencing. I think too that to a certain extent, I make a living about from helping patients manage their conservative care for their back pain. So I'm not a surgical specialist. And I can see that some patients are very wary of surgery. And I think that's because, unfortunately, in the past, some surgeons have sort of gone overboard with their treatment of back pain. But I say to patients all the time, I'm so proud to be working with a group of surgeons here at Cornell, because sometimes I will send a patient to Dr. Ellowitz and I'll say, this person might need some surgery. And he'll say, I think we should try some conservative stuff first. So, as a whole, the surgical department the neurosurgical department at Cornell is quite conservative, and they're only doing surgery if they're absolutely necessary. And so we're committed to really following patients through almost every conservative treatment we can before we get to that surgical level. So that's sort of where I come in. I'm guiding patients through their exercise, through management of medications. I think one of the questions mentioned pain medications in general. Usually when patients are talking about pain medications, they're talking about opioids, but certainly opioids are not the only way to treat pain. And in fact, the newest model for treating pain medically, which is with medicines, is really to pick medications from a variety of different families that act on different receptors, act in different ways, to really try to tackle the pain from a variety of different perspectives, not to just give you a medication that makes you feel sleepy, drowsy, and potentially addicted to a medication, such as an opioid. That being said, there is an appropriate time to use opioids. Usually it's when there's somebody's in an acute flare-up of pain. However, chronic use of narcotic opioid medication has fallen out of vogue a bit because of the addictive potential.
Excellent. Yeah, and I second that too. When I send patients to the neurosurgery team, including Dr. Ellowitz, when they say surgery is indicated, then I know it's legitimately indicated, and I really feel comfortable about that, which is always nice. So let's switch gears a little bit, because there's a lot of questions coming up about more of the diagnostic side of things. Dr. Miccio again, and for this particular one, there's a couple questions coming up about how you can tell the difference between neuropathy or nerve pain in other areas of the legs versus nerve pain coming from the back. Does peripheral neuropathy come from spinal stenosis? And there was a similar question, can muscle pain or muscle tightness cause things like sciatica? And I know a lot of this can get really tricky. So how do we sort out the neuropathy versus the muscle versus the spinal stenosis? How do you do that? How do you approach that?
Sure. we have a lot of technology at our disposal these days, but to be honest, you always return to the basics. So anytime you have a patient in front of you, you're going to ask them specifics about what type of pain they have and where it is. So there are distinguishing features that tell you that this is possible from peripheral neuropathy, something that may come from something like diabetes or something like that, that is can be distinguished from pain coming from the back. There are many, many nuances, and honestly, in that regard, that is a situation where I may refer to Dr. Weaver, who's here right here, to do an EMG to parse out whether something is coming from a peripheral neuropathy versus a neurologic issue in the back. That is sort of a perfect indication for an EMG. So you take an appropriate history and you do a good, solid physical exam. And there are some clues on physical exam that help you narrow things down to whether something is coming from nerve impingement, a pinched nerve in the back versus elsewhere. All of the tests to determine whether something is musculoskeletal or neurologic, they're not very good. You got to take them all in context. You have to take a bunch of tests, put them all in the context of what the patient is telling you to really come up with an accurate diagnosis. And that's what makes it complicated, and that's where the art comes in. Real quick, somebody asked about muscle pain and nerve pain. Often when a nerve is irritated, the muscles that are innervated by that nerve will get quite crampy, and patients will have a lot of muscle cramps. That is often what I see. I often don't see muscle cramping causing nerve pain. I often see nerve pain causing muscle pain.
Right. I think that's fair. That was great. Dr. Ellowitz, so we were talking about nerve, muscle, other areas of the body, but even sometimes it gets tricky within the spine itself when there's multiple levels. So Darlene had mentioned here having narrowing at L2, but a rupture at L5-S1. How do you tell where the pain is coming from if you've got multiple areas of the spine affected? And actually someone had asked earlier, Deborah, I think, about what exactly is rupture? What does rupture mean? So if we can just go into those.
Sure. Well, let me start off with what rupture means. If someone has a herniated disc, it means that the inner portion of the disc, which is softer, has come out. The disc has like little cushions or shock absorbers, in a sense, between the bones. And there's a tear, a weakness in the outer part of the disc. Some of the inner disc could come out. Sometimes we make the analogy of toothpaste out of a tube, and that could cause a pinching of nerves. A lot of terms for that. Sometimes people say a ruptured disc or a slip disc, but I think medically we usually use the term herniated disc. But I think there's a lot of different variabilities just in terms of the jargon that may be used. Now, you're getting back to how do we determine what is causing a patient's pain? It's very typical that we will see multiple issues on the MRI scan. In fact, it's very rare that someone will have a normal MRI. I think I can go a whole year plus of seeing patients and not see a patient that has a normal MRI reading. And even in 20-year-olds, and this has been done, taking people off the street, they have no symptoms, no pain whatsoever, and virtually all of them will have some abnormality of the spine. So part of what we have to do is determine what is within the range of average, not just normal. Then if we see other findings, such as a herniated disc or stenosis and narrowing of one area versus another area, that's where speaking with the patient, getting the history is so critical in examination. For instance, if someone may have spinal stenosis, which is the narrowing, that takes years and years to develop. And if a patient has acute symptoms, then maybe that just started a few weeks ago, and the MRI shows that there's something new, like a herniated disc, well, I think we could feel in general comfortable that the problem is the herniated disc rather than something they've had for years. But again, that has to take into consideration, I may send the patient to Dr. Weaver as the neurologist. He may do something called an EMG, or nerve conduction study, actually checking the nerves, because this is a particular concern. You may send the patient to Dr. Miccio to try an injection as a test, as a diagnostic test. He may block one area, one nerve to see, is that causing the pain or another nerve? So we have a lot of different options to help determine what is causing the symptoms, but the most important one is really speaking with the patient, finding out about their history and symptoms, and as well as the physical when that's appropriate.
I think that that's actually the perfect scenario where there's more than one finding on MRI that could potentially be causing symptoms. That's the perfect scenario actually where we as a practice all come together and we talk about it. So believe it or not, you know, for the last hour before this webinar, we were on a Zoom call coming together as a practice to discuss complex cases with radiology, neurosurgery, neurology, interventional pain, including myself from rehabilitation and my colleagues from anesthesia, all coming together to ask these very same questions, to say this patient has multiple issues on their MRI, these are the symptoms, what do we all think? So, you know, it's pretty common to see practices touting multidisciplinary care these days. There's another thing to do it. And we actually do it on a weekly basis where we all come together and we discuss these cases to make sure that we're getting the right diagnosis, the right treatment for patients.
Excellent. Yeah, I just want to clarify because it came up a couple times on the chat. Neuropathy, what we mean when we say neuropathy, usually we're talking about a peripheral neuropathy that occurs in the legs or the arms. This is a direct problem with the nerves, so a problem with the nerves directly, not having to do, you know, from the neck or the back. So many people have both, as neck or back problems are really common, but when people have direct nerve problems in the legs, that's what we use the word neuropathy to mean. So they are separate issues. So the most common things being diabetes or vitamin deficiencies. Those are two very common reasons why people can have nerve damage in the legs or the arms directly, not coming from the back. So just to clear that up. And that's where, you know, Dr. Ellowitz and Dr. Miccio have mentioned doing nerve tests and things like that, like the EMG, can be really helpful to parse out what's what in those cases. Dr. Miccio, I love that you brought up the spine conference that we do weekly. Linda G had a really good question here, which is, do we usually agree on what the course of action is when we discuss these things? And that's an interesting question, I think. I'm curious to hear your thoughts on it.
I think we come to a consensus is accurate. Because sometimes I say to patients, unfortunately, there's no medical textbook where you turn to page 384 and it tells me exactly what you need. It doesn't exist, which is why this is so complicated and why this is an art, is that pretty much any treatment, you know, I think we agree on diagnosis fairly regularly. It's not the diagnosis portion of things, it's more along the lines of the treatment, because, you know, people have symptoms from the faintest of discomforts to the most severe of symptoms. Unfortunately, we don't have treatments that address every iteration of those things in between. What we have is we have these things that address segments of dysfunction. So we have medications, we have exercise, we have medications, we have injections, we have surgery, a few things in between, but sometimes we have patients that are in between, where you know, medication and exercise seems to be appropriate. However, we're leaning a little bit more towards injections, or some injections have helped. However, it's not working quite as much as we'd like. We're leaning towards surgery. So there's sort of this ebb and flow that exists, and it also very much involves the patient. So it has to be in line with what the patient needs, what the patient wants, and their own personal goals. So we come to a consensus, but there are a variety of ways to do things, definitely.
I think that's a great answer. And Dr. Ellowitz, you know, a lot of patients seek out multiple surgical opinions. So when we come to the consensus that surgery is the answer, I feel like even then it could be confusing in terms of what kind of surgery should we be doing. So maybe you can comment on that a little bit about what we do at the Spine Conference and, you know, your take on that as well.
Yeah, I mean, I think that's a great point. we may come to a consensus that surgery is necessary, that the patient meets the criteria, that there's something we could do to help. But then we, as surgeons, have to come up with an actual plan, an actual strategy. I think we have a general, I won't say uniformative opinion, but a general philosophy of trying to do minimally invasive surgeries when we can. Certainly the vast majority of patients that we see, we find we can treat in a less invasive fashion. But that's one of the reasons we come to a conference such as this. Not only is it to see are there other options, other alternatives aside from surgery, but also speaking with my surgical colleagues to see what do they think. Is this how they would approach the case? In addition, we also have specific spine surgery conferences just among the surgeons with our own group, sometimes with the surgeons at other hospitals, including with the spine surgeons at Columbia and HSS. We have joint conferences discussing individual patients. And I find that extremely helpful for me, for my practice, and really helping patients to get a group opinion. And that's really what we do here.
Excellent. Complete side note here. Someone asked that they heard the EMG was quite painful, and is that true? I will just address that because many people in our spine center ultimately end up getting a nerve test at some point. So it is a pretty common part of the diagnostic workup. I'm not going to sugarcoat it. I don't think the EMG is a particularly fun test. I think it's a little uncomfortable. I've had it myself, so I know what it feels like. The overwhelming response from most people, at least for the ones we do here, is that, oh, that wasn't as bad as I thought it was going to be. So for those of you who don't know, we apply an electrical stimulus, so you feel a little shock, basically, and a bunch of little shocks, over and over, which again, not something you'd want to do for fun, but it gives us a lot of very good information about how the nerves are functioning. So it really helps in terms of, figuring out the diagnosis and ultimately the treatment plan. The EMG portion of the test, we use an acupuncture-sized needle, so it's very small, and we put that in the muscles one at a time. But you'll feel the pinch of the needle, which again, not pleasant, but most people find it's not that bad and it's pretty manageable. So just to put that out there, in case anyone ever needs one. Maybe why don't we run through your cases that you had prepared? I don't know, Dr. Ellowitz, I think you had a case after the slide, if you want to run through that.
And if you have the control, we can move ahead.
Oop.
Yeah, right there. So, this is a pretty typical patient that we will see at our spine center. This is a 48-year-old woman. She had a long history of back pain, but over the past 2 months, she developed right leg pain. What we're looking at is on the image on the left. These are both slices of the MRI. The image at the left is looking at the person from the side, like in profile, where as if they were looking toward the left side of the screen. And the squares that we're looking at are the bones. The darker lines are the discs. And you notice not at the bottom, the next one up, we'll call it L4-5, a little bit of a misalignment. And next to that is a oval, oblong, whitish structure. If we look at the images on the right, yeah, thank you. These are slices looking straight down on the spine, kind of like we could slice a loaf of bread. And where you have the arrow, on the image on the right, on what we call an axial image, there is a little whitish area. And also when we look at these images, it's reversed. So that what you're seeing on the left side is actually the right side of the body. And this little rounded area is called a synovial cyst, something I see a lot in my practice. Synovial cyst is an area where some of the fluid of the joint has leaked out. People hear cyst, they think of a tumor. It's nothing like that, based on an arthritic type of cyst. And that can cause a pinching of a nerve and quite severe sciatica. So I think it's pretty clear what is causing the pain, at least this 2 months of severe pain, which is that cyst. So we have a lot of different options. I mean, I can go in to remove that cyst, but we have a few other options at the spine center. Dr. Miccio, if you want to talk about that. You know, if we decide the patient said, you know, let's try something else. It's not just rushing to surgery, and I'm always very open to that. What other options would you have as a rehab doctor if I brought you in, called you, hey, come, Vince, why don't you come in, let's see this patient together.
Sure. So I'll go back to those kind of continuums that I showed on the previous slides here. So a lot of this depends on how much distress she is in and how it's affecting her. But let's assume that this is causing her some really severe discomfort. Another dimension of this is sort of that that continuum that I talked about previously with exercise, medications, injections, and surgery. I almost view that as rungs on a ladder. So, you know, rung number one is sort of this exercise realm. Rung number two is medication and then injection. So it's sort of, you know, we're upping the ante a little bit each time. But like I said, I don't want to undertreat people and I don't want to overtreat people. So this person may come to me and she could have severe debilitating pain associated with the compressed nerve that we see here. If the patient has nerve pain in a distribution that corresponds to that compressed nerve root there, then I would probably offer them some form of injection to help treat their pain. You know, usually we progress along that exercise, medications, injections way, but some people need it in a different order. Some people need the injection first to get the pain down so they can tolerate the exercise and such. And so in this case, we would seek to put some medication around that inflamed nerve. Sometimes I would try that first, just to put medication around that inflamed nerve. Depending on the patient's response, we may seek to rupture that cyst. And that cyst is clearly pushing on the nerve here. When that cyst is ruptured, often patients do experience a good amount of relief, but the cyst can return. And if we find that the cyst returns on a regular basis, then I may refer to someone like Dr. Ellowitz to go ahead and surgically repair it. As a side note, if we do an injection and the pain gets cut down significantly, often I will formulate an exercise plan for the patient so that they can move into that maintenance phase where they can hopefully get some long-term relief.
Excellent. Thank you, Dr. Miccio and Dr. Ellowitz. That was really great. Dr. Miccio, do you want to briefly go over your case as well?
So the case that I have here is slightly more complex, and it just sort of illustrates how we work together. So this is a man in his 70s with chronic back and leg pain. He had surgery in 2016 and had a mild to moderate reduction in pain, but it really wasn't a home run necessarily. That was done at an outside institution. Around late 2019, he had a return of some of his discomfort in his feet, and he also noted that he had some numbness in the legs and feet. We obtained some MRI imaging, which showed severe lumbar stenosis at the L2-3 level, which is above the area where he had surgery previously. And neurology weighed in with an EMG, which actually showed some evidence of neuropathy that is superimposed upon some of the discomfort he may be feeling in his legs from the narrowing of the spinal canal, which you can see by the arrow that I'm indicating here. So his history and his examination was most consistent with what we call lumbar stenosis, which is a narrowing of the central canal here. And it often, as Dr. Ellowitz said previously, it often leads to discomfort with walking that is relieved with sitting. And it can often be associated with a feeling of heaviness and tiredness in the legs. So not just pain, but this feeling that the legs just won't go any further. I performed some injections for him to address that, and they helped him for a bit. They helped him, they bided him some time, but it was obvious that he needed some form of higher level care. At that time, I actually sent him to see Dr. Ellowitz, and Dr. Ellowitz noted that the overall risk of performing the surgery for this patient, it outweighed the potential benefits of doing it, which is an opinion I very much respect, because I think the stereotype of surgeons is that they'll do surgery at the drop of a hat, but that's simply not the case. So what we are doing now is we're actually evaluating him for a spinal cord stimulator, which is a non-surgical treatment modality that involves inserting a small wire into the epidural space along the spine. And that provides electrical stimulation of the nerves to modulate transmission of pain from the painful area to the brain. It can be helpful in those in which spine surgery is not the best option. So you can see there's a variety of players here in this complicated case, and everybody has a certain subset of expertise that they bring to the table here.
That's a really great case and very illustrative about, kind of how we work and how we operate here. I think that's wonderful. We are kind of nearing the end here. I did want to just throw out one more question, actually to Dr. Ellowitz. Someone had actually emailed this in before, and I think it's a really great question, which, as you noted, sometimes surgery has more risks than benefits, and sometimes surgery is only temporary. You get a fix for a while, but sometimes people come back with more pain. If you had a patient that you had done surgery on, and unfortunately a year or two later came back with maybe a different kind of pain or the same recurrence of pain, what would you do? Where should they go? I mean, it's kind of daunting when we have so many different types of doctors here. How do patients know how to navigate that?
No, I think that's a great point. I think that if someone has had surgery and if they have additional issues months, years later, and it definitely does happen, we know that, I think the best thing is at least to call the surgeon's office. Very often, if it's been a very long time, if it's been years, then we may say, well, let's back up. We don't have any new MRI scans. Let's at least have you see one of our neurologists, one of our rehab doctors. Let's evaluate you from scratch in the sense that maybe something else. It may not be directly related to the surgery. Obviously, if it's much closer to the time of surgery, months later, then I think they should be evaluated by the surgeon. And anything in between, at least to give the surgeon's office a call so that they know where to treat, where the best person, where the best specialty, to at least start the evaluation. It may wind up getting back to the surgeon, but still we need to have this overall, this sort of comprehensive view, and not just think, oh, person needs to be jumping right back to surgery again, because that's not always the case.
Excellent. Well, I think it's actually, we're past time, actually. I wish we had 2 more hours to discuss this. There were so many good questions coming up. So I really appreciate this. Thank you, Vince, and thank you, Eric. I just want to say, I think the take-home message here is that a multidisciplinary approach to spine care can really improve not only the diagnosis, but also hopefully the outcome, that people have. I noticed in the comments a lot of people talking about not only nerve pain, but muscle pain and joint pain and all these other things. And even within our subspecialties, we do have people who are experts within certain areas. And, I think it can be daunting. It's not really necessarily up to the patient to decide, to know where you need to go. And we are here so that if you have a connection with one of us, we can connect you with the appropriate people, within our group. And so we're always happy to do that and work together as a team. So I think that is everything. I hope that everyone is staying safe, and we look forward to continued discussions regarding spine health. Take care, everyone. Have a good night.
Thank you.
Thank you.